So we're recording now. It is Wednesday the 24th of October. Have James Owen doing his 12-lead ECG assessment. There's 2 ECGs for you to interpret.
Okay.
So what I'm going to do is I'll put one face down in front of you.
Okay.
And then you've got 1 minute to make any notes that you want on your piece of paper. So I'm just going to put one down there, and
okay.
now you've got a minute from there. Right, you know,
So,
around a minute. Don't turn it over
okay.
yet. Just notes as to any prompts or anything that you want. You ready to go?
Yeah, nearly, just about. Okay. Okay.
Okay, so if you can turn it over and read out what number it is.
ECG number 4.
Okay, I'll give you a scenario you need to listen to.
Okay.
You've got a 52-year-old male on the golf course for 20 minutes.
Yeah.
Developed central chest pain and vomited. There was a conscious collapse, witnessed, non-injury.
Okay.
The golf partner called an ambulance.
Yeah.
And the patient is pale and sweaty with 7 out of 10 pain.
Central chest pain.
Do you want me to repeat any of that?
Just one more time.
Read that
thanks.
again.
Yeah.
52-year-old male on the golf course for 20 minutes.
Yeah.
Developed central chest pain and vomited. A
Yeah.
conscious collapse, witnessed, non-injury. Golf partner called the ambulance. He's
Okay.
pale and sweaty, 7 out of 10 pain.
All right.
So, you've got 7.5 minutes. I'll tell you when you've got a minute left to go through and interpret it, and at the end, I'll ask you for your interpretation.
Okay.
Yeah.
All right. So do I start verbalising now?
Yep.
Okay, so the first thing I look at is the AVR. The vector is negative. There is a QRS complex in every lead. The R wave progression in V3, it's not equiphasic, so therefore it looks like it's a slow progression. The ECG is good, it's nice and clean, hasn't got the paper speed, hasn't got the frequency response. The calibration spike is 0.1 0.20 seconds by 10 millimetres. There's no date. We know the patient is a 52-year-old male. Just looking at the ECG, it looks regular. I'm just going to count between the R waves how many squares, which we then divide by 1500. So I'll just quickly do that. So that's 18 divided by 1500, so I'll just use a calculator. So we have a rate of 83 beats per minute. Just looking at the ECG, the concerning morphologies, I can see there's ischemia in leads 2, 3 and AVF, and that's elevation, and there's some depression in AVL, V1, V2, and just looking further on there's actually some elevation in V4, V5 and V6, so that would be our concerning morphologies at the moment. Just looking at the P waves, they're upright, they look normal to me. The QRS complex, just going to count the squares. It's between 0.08 millimetres to 0.11 millimetres, so that's normal. The ID, which I'll just find the most equiphasic, the ID is less than 0.04 millimetres, so that's normal. Just going to look at the QT interval next. Just going to count the squares. 18. Okay, so the QT interval is normal. The way we work that out is we count the squares between the QT, and if it's half of the rate between the RR pattern, then it's normal, which it is. Just noticing now that there are some Q waves which are very small in lead 2, 3, AVF, but none of them are a third of the R wave, and none of them are too wide. Just looking at T waves, there's no. They all look normal in morphology. I can't see any. There's possibly a biphasic one in V1. Yeah, other than that, it's quite normal. There's no bundle branch blocks on this ECG because the QRS complex is narrow. It's between 0.08 and 0.11 millimetres. There's no left ventricular hypertrophy, so that's good. But my biggest concern is that in the inferior lead, which is 2, 3 and AVF, we've got elevation which is greater than. It's just grab a piece of paper. So in lead 2 it is 2 mil, in lead 3 it's 2 mil as well, and then in AVF it's 2 as well. And in the high lateral leads of AVL we've got probably I'm going to say we've got 0.5 millimetres of depression, so that tells me that there's some reciprocal changes. We have got some ischemic signs in the septal leads. We've got depression, which is, just count that, which is about in V2 it's 3 squares and in V1 it's 2 squares, so there's ischemia there. We've also got some elevation in the anterior lead of V4, which is 1 mil. In the lateral leads we've got elevation of 2 mil in V5 and 2.5 mils in V6. So that's quite a concern, this sort of widespread
You've got 1 more
ischemia.
minute to go.
Okay, yes, for me there's an inferior STEMI, which involving 2-3 and AVF with reciprocal changes in AVL. This also fits with the patient's presentation of having crushing chest pain with the collapse, the vomiting. Yeah, just make sure I've covered everything. I've missed one thing, which is the cardiac access. So I'm going to use your 2 thumbs technique. So in lead 1 it's positive and AVF it's positive, so that's a normal access deviation. Just going to look for, yep, and that's it. That's what I can see.
Okay, so can you just say again your interpretation then?
So there's a inferior STEMI, and there's some ischemic changes in the septal leads and the anterior lead of V4, and there's some lateral ischemia as well in V5 and V6.
Okay.
Yeah,
And I've got a couple of questions about the scenario. Okay?
I've just missed one thing as well,
Sure.
so I just mentioned.
Yep.
The PR interval is between 0.12 and 0.20, so that's also normal.
Okay.
It's not too long.
So 2 questions. The first one, what arteries are likely to be involved if this person has right coronary dominance?
If you have right coronary dominance, this is something that I think 8 to 10% of the population have, and it can involve the circumflex and the posterior descending artery, I believe. Yeah.
Okay. Ready for the next question?
Yep.
What are reciprocal changes and what do they show?
Firstly, reciprocal changes demonstrate that it's a STEMI presentation, and what it is so for this, I'll use this as an example. The inferior leads are looking at the heart, the bottom of the heart, and the high lateral leads are looking from up here. So it's actually an opposite view. They both look at the opposite. So one's elevation and one's depression. So you have that opposite view going on.
Okay. Radio. So that's that one. You ready to move on to the next one?
Okay, yep.
So same thing, so don't panic.
Okay.
Put that down there. And you ready? So I'll put it face down again. And same thing, you've got approximately a minute to make notes, or you're going to use the same answer?
I'll just use the same thing.
Oh,
again.
okay. So if you could turn it over and tell us what number it is.
Okay, so this is ECG number 3.
Yep, so the scenario for number 3. You've got a 20-year-old male with shortness of breath and palpitations. He has some chest pain. And that's all I can give you.
We've got some
20-year-old male, shortness of breath and palpitations, and he has some chest pain.
So that's a 20-year-old male.
Yeah.
Okay.
So when you're ready to start, you've got your 7.5 minutes again. So.
Okay, so I'll start in the beginning.
Yeah, okay.
AVR, the vector is negative. There's a QRS complex in every lead. The R wave progression is late. The ECG is a good ECG, it's very clean. We haven't got a paper speed. We haven't got frequency, but we have the calibration spike, which is 20 millimeters, 0.20 seconds by 10 millimeters. We haven't got a date, but we know the patient is a 20-year-old male. Just going to look for regularity. And again, it's a regular rhythm, so we're going to work out, hang on a minute. On this one I'm going to say that the rhythm is regular, but I can see seems to be an ectopic beat here, which has sort of upset the underlying rhythm. So I'm going to say that this is regular. So I'm going to count between the RR and divide by 15, so it's so we've got a rate of 75 beats per minute. At the moment, our concerning morphologies, I can see some elevation in a septal lead, which is V2, and some elevation in V3, V4 as well. However, I'm going to come back to that because I'm going to explain something else that's relevant to that. There doesn't look like there's any other concerning. No, there's nothing else there. So looking at the P waves, they're slightly flattened, but there is one before every QRS complex. The QRS is wide, not just in each lead. I'll just count that. So the QRS complex is greater than 0.12 millimeters, and just looking at the QRS complex, to me it looks like there's delta waves there, which is brings me on to the PRI interval, the PR interval. Because there's these delta waves, it's a shortened PR interval, which is, just work that out, it's less than 0.12 millimeters, so it's around 2 squares, so it's 0.08 millimeters, which is a shortened PR. As I said before, that's to do with the delta wave, which I'm going to explain about in a minute. The ID, find the most equiphasic. The ID on this particular ECG is greater than 0.04 millimeters. The QT interval, which I'll just work out, the QT interval is normal because it is not half the RR rate. Just looking for Q waves, there are Q waves in leads 2, 3, AVF, and that's it. But the Q waves in lead 2 are not a third of the R wave, so doesn't equal it to be pathological. In lead 3, you've got a QS, as in AF, you've also got a QS, so there's no R wave. So again, I would say they're not pathological. So the fact that this ECG has got a wide QRS complex, it's not a bundle branch block, it's not hyperkalemia. I'm going to say that this is Wolff-White Parkinson because of the delta waves and the shortened PR interval. There is some left ventricular hypertrophy because in lead 1 the R wave is greater than 12, and in AVL the R wave is greater than 11 millimeters. So that's greater than 12 millimeters in lead 1, greater than 11 millimeters in AVL. So that indicates left ventricular hypertrophy. Just looking at the ischemia, which I mentioned earlier that I could see in V2 and V3. This is a 20-year-old male, and when you have a 20-year-old male, the mass of the heart is a lot greater. So there might be ischemia here, but it's not greater than 2.5 millimeters, and therefore doesn't indicate ischemia.
You still have another minute if you need it.
Okay, so in V4 we've also got some ischemia as well, but that lead is in isolation, so that indicates that it's not ischemia. So I'll come back to my interpretation.
Yeah.
The axis, I did a cardiac axis, so I'm going to use the two thumbs. So we've got lead 1 is positive, AVF is negative, so we have a left axis deviation. So looking at this ECG, I'm going to say that this patient has Wolff-White Parkinson's disease because of the delta waves that are widespread and the shortened PR.
Okay. So
Just to say that the T waves, there's none that are 2/3 of the R waves, so there's no ischemia there. All right. Yeah,
okay. Couple of questions then. What is the accessory pathway known? Hang on. What is the accessory pathway known as in WPW, and
Yes.
why does it show a widened QRS delta wave?
Okay, so it's called an orthodromic, meaning that it's wide. So what happens is this accessory pathway with Wolff-White Parkinson, it goes to, if I can remember, it's either the bundle of James or the bundle of Kent. It's orthodromic, which means it's wide, it's broad, and it goes to, I think it's the bundle, I'm going to say the bundle of James. It's the bundle of Kent, and it's an orthodromic re-entrant pathway. That's what I'm going to say.
Okay. How would you determine whether AVRT is WPW or LGL?
Or long. LGL doesn't have the delta waves. The PR segment, I believe, is still shortened, the same as Wolff-White Parkinson, but the difference being that they don't have, LGL does not have the delta wave. Yeah.
Okay. In that case, that's it. Finished.
All done?
So I'll stop recording.